My job here is to talk about what is the strategy for relapse treatment in AL amyloidosis. I'll gloss over some of the data because you've seen most of that, but we can focus on what we might do in certain settings. So what are the principles of treating relapse? What do we need to think about? So the main thing is what Monique showed earlier. What is progression? We have to decide when a patient is first progressing. We have the ISA criteria, which are at a very high level of light chains. We often don't wait for that. We need new criteria. Our Italian colleagues presented to us what's defined as high-risk DFLC progression, which is progression from very low-level light chains when the light chains increase, and we certainly follow this a lot more in clinical practice. We have a proportion of patients who are treated with the initial treatment, but we don't normalize their monoclonal protein, so they get a VGPR with evidence of end-organ progression. I think this point is now becoming even less relevant because one has to question whether VGPR at all is something that should be considered acceptable, because what we are seeing in some cardiac patients is that we see an NT-proBNP response to begin with. But then 2 years later, we start seeing progression, which means that we have changed the rate of progression. We may have changed the trajectory of the disease, and we think very happily that the patient isn't progressing, but our trajectory of progression is very, very different. Then I presented to you data somewhat earlier that we have got complete response. We can use whatever definition we want, but these patients have evidence of minimal residual disease by either flow cytometry or by mass spectrometry. And these patients then get no organ response, or we don't see evidence of organ response. And again, maybe these are some patients where we need to consider deepening the response by more treatment. So this is not necessarily relapse, but this is what might be defined as an inadequate response. And when we start thinking about how do we treat next, we've got another set of considerations which come up. What was the first-line treatment? How long was it given? Was the patient on maintenance treatment for 2 years, or did they just have 3 cycles because they were too unwell to receive a lot of treatment? And how deep was the response to the frontline treatment? We, of course, have the functional status of the patient, and we'll talk about that in a minute. And then we have got this really, really challenging point. What is the funding and the availability of drugs? We heard quite a lot in the meeting about venetoclax, which is available in some countries, not in others. I, of course, work in what I consider to be a seriously resource-restrained country, which is the United Kingdom. So we have got very strict restrictions on what treatments we can use and how we can use and what order we can use them. And we have to be very mindful of that when we think of treatments. And there are certain treatments we use that we may not be using if our resources had been less restrictive. For example, an autologous stem cell transplant. One thing is very clear, and this is just one of the studies. This is from the Mayo Clinic, which has looked at patients who are relapsing. And within the relapsing patients, they are looking at patients who have a heme progression versus patients who have an organ progression versus patients who have both an heme and an organ progression. And at any time, if you have got evidence of organ progression, the outcomes are much worse. And at any time, if you've got heme progression with organ progression, the outcomes are even worse. Whereas patients who are retreated very early, before there is evidence of organ progression, the outcomes are better. So we need to treat early, and what we don't know is how early is early. Do we treat when the light chains have gone up by 10 milligrams, or do we treat when they've just gone outside the normal range? And I think we need some more data and some studies to decide what is that optimal timing before organ progression has occurred, but when heme progression is starting to occur. I showed this slide at ISA about what can be staging for amyloidosis, but these are also the risk factors that we have to consider both at baseline, but also at the time we start thinking about treatment. The organ function, the biomarker-based staging system, all of that is very important at baseline. Some of it may not be so important at the time the patients are relapsing because the organ function may have improved, patient may have clinically stabilized. But we have to think about what happened with the clone at presentation. Did the patients have significant bone marrow plasma cell infiltration, or did they have what we might say be a true MGUS? We talked quite a lot about cytogenetics so far. Did they have 11-14 translocation? Did they have something else? And then what happened to their first remission? I think that's a really important point that we don't consider. How long was the duration of the first remission? We had a lot of data on cytogenetics, but when we were using only bortezomib, it was very clear that patients who had 11-14 didn't do so well with bortezomib. This is data from the Andromeda clinical trial. The graph is a bit small, you might not be able to read. But essentially, it's trying to show that the complete and the very good partial response rates across different cytogenetic subtypes are very, very similar. We don't have data as yet about the time to progression or overall survival, but it seems that if you use DARA, maybe some of the high-risk markers are not as important, although there is likely to be data coming that shows that maybe patients with 1Q don't do so well. This is data on the left-hand side with melphalan and on the right-hand side with DARA from the Boston group, and I think the left one is from Stefan's group, showing that if you have a 1Q gain, you do much worse than if you don't have a 1Q gain. So maybe we need to think about patients with 1Q gain in a different way than we think about patients who don't have this particular cytogenetic marker. And this is very simple. Increasing bone marrow plasma cell percentage, outcomes are worse. This is data from the Mayo Clinic. And below is data from the Spanish group looking at flow cytometry and looking at the profile of the bone marrow by flow. If the bone marrow profile is like MGUS, the outcomes of patients are much better. That's these curves. If they've got an intermediate profile, they do less well. But if they've got a myeloma-like profile, at least in this small subset, the patient's outcomes were much worse. So we can use various different means of deciding whether the patients are myeloma-like or not to figure out how our treatment goes. We talked about duration of treatment and intensity of treatment, and again, we might be able to use this to make those decisions. And then we showed some years earlier that patients who relapse within 2 years of their initial treatment have much worse outcomes compared to patients who relapse later. And this is independent of what their initial response was. Whether they had a CR or a VGPR, they still did worse if they relapsed early, and they did better if they relapsed later. So what do we have right now in terms of our patient population at relapse? Majority of our patients, apart from some of Arno's patients who are treated with melphalan, will have them treated with Dara-Cybo-D. We still have a number of patients who are still in remission after initial bortezomib-based treatment or melphalan-based treatment or stem cell transplant who are relapsing. This is becoming a minority. So we have progression on DARA maintenance. We have patients who never had daratumumab. Or we have patients where DARA was given but then stopped, and then they will progress without being on DARA maintenance. So these are our three main groups of patients when we talk about disease progression. And then based on that, we can decide whether the treatments go ahead. Certainly within our practice, one of the things to consider is the patient transplant eligible or is the patient not transplant eligible? And then we have the cytogenetic marker, is the patient T1114 positive or negative in each of these cohorts. I think for the patients who haven't had DARA, the answers are very simple. Give them a DARA-based regimen. Whatever DARA-based regimen you have, single agent, combined with bortezomib, combined with an IMiD, it works. And it works really well, and you get deep responses. This is UK data. We've got second-line Dara-Velcade Dex. And what we are able to show that in patients who are treated DVD second line, we get quite a lot of deep responses in this patient group. So about 50-55% CRs in this patient group. And patients who get a CR, their progression-free survival is very good. But within this, we had two groups of patients. We had some patients who had relapsed after CVD, and we had some patients where they went to second-line DVD after they had what we considered an inadequate response to CVD. And in that setting, the responses to DVD weren't as good as patients who had actually had a deep response and then relapsed. So for DARA, not exposed patients, answers are pretty straightforward. The second treatment that we often do is a stem cell transplant. You saw some of this data before about the delayed versus early stem cell transplant. This is our experience with stem cell transplantation. And what we have realized that we have looked at cohorts from 1994 until 2018. And a median time to a patient going to transplant has crept up over the years from initially being transplanted early to now most of the patients being transplanted at a median time of approximately 18 months after the initial diagnosis. And the outcomes have improved over time. And this is the Mayo Clinic data. Someone showed the slide in one of their previous talks that patients, whether they have an early transplant or a late transplant, outcomes are fairly similar. Reasons why the transplant was delayed were very different. In some, it was consolidation, and in a small proportion, it was evidence of relapsing disease. So delayed transplantation has a role. There isn't much data on what exactly happens in second-line transplantation. This is one of the papers from the Mayo Clinic looking at second-line transplantation for relapsed refractory AL for patients who had a first transplant. And again, patients who had a long remission following the first transplant, the outcomes on a second transplant are very good. Patients who needed intermediate treatment or patients who had a shorter duration between the transplants, the outcomes are not so good. So patients who have long remission, maybe second transplant is a possible answer. This was a presentation at ASH now 3 years ago, looking at what happens if you do a transplant in a patient who's not responded to frontline treatment. So patients were refractory to induction chemotherapy, And in that set of patients, the improvement in response was actually very limited. So these were patients who were refractory. This is what happens after the transplant. You can see that the number of patients who get a CR is very small, and the CR plus VGPR combined is only 40%. So if you're truly refractory to a frontline treatment, the benefit you might get in terms of a deep response following a transplant is small. And you probably need a second-line treatment before you have a consideration of a transplant, if that is one of the treatments you want to consider. Certainly within our own practice, we pay quite a lot of importance to the bone marrow plasmacytosis. So patients who have more than 20% bone marrow plasma cells, this is probably about 20% to 25% of our patients. Those who present with high presenting light chains, and haven't put a number in there, it's kind of generally a vague thing. Patients who relapse early, patients who have 1Q gain, and then we've got these two things, lack of access to novel therapies. We are quite limited in what treatments we can access, so we would base our decisions on what treatments we can't access venetoclax. We've got limited access, particularly if the patient had DARA frontline. We don't have access to DARA second line, and therefore we often harvest our patients after the frontline treatment for transplantation later on. And in resources where treatments aren't accessible, this certainly remains a useful therapy. We talked a little bit about lenalidomide, pomalidomide, and other proteasome inhibitors, and I'll briefly touch upon this. We don't really like lenalidomide much for amyloid patients because it's not well tolerated. This is long-term data presented with the Italian and the German groups, showing that you do get responses, but the complete response rates, of course, are very slow. And patients who have high-risk features, in this case it was 1Q gain and high light chains, the outcomes, the responses weren't that long-lasting. We think pomalidomide is better. Sorry, I forgot about the slide. Ixazomib lenalidomide dex is one of the regimens that we use quite a bit in UK because it's, again, accessible to us. And we published this now quite some time ago, showing that we can get good responses even in patients with cardiac amyloid. The response rates, CR plus VGPR, are about 50%. But what's interesting in this is that there was a group of patients who got a CR and VGPR in this cohort. And about half or more than half of these patients, many years down the line, still continue on IRD because they still remain in CR. And we certainly find that we can use very small dose of len, maybe 5 milligrams, maybe 10 milligrams, and still get a good response, and the tolerance is not as bad as you might get with single-agent lenalidomide. So I think IRD is certainly a potential regimen that you can think about if you wanted to use a len-based treatment. Pomalidomide is better tolerated in AL. We like pomalidomide. This was a joint series that we published a couple of years ago, showing that you can get CR or VGPR in maybe about a quarter of the patients, but most of the responses were still partial responses. But when we combine pomalidomide with daratumumab, the responses are much better. We don't have a lot of data on this, but this was a more recent paper showing that the combined CR-VGPR rate, particularly in this series, 6 out of the 9 patients treated had a CR when treated with darapom. So certainly a regime to consider if you wanted to use an IMiD-based treatment. This is a very controversial topic, carfilzomib in amyloidosis. And it wasn't mentioned in any of the talks all of this morning, apart from where the toxicity of the PI of proteasome inhibitors was considered. And certainly it is a true problem with carfilzomib, particularly when it's used twice weekly. There was a phase 1 clinical trial done where carfilzomib was given twice weekly as per the protocol, and there were a couple of patients who unfortunately had serious cardiac problems with carfilzomib. We used carfilzomib in a small number of patients who had very severe peripheral and autonomic neuropathy where we could not use bortezomib. And we were able to see rapid and deep responses in this group. And this was what we published, and we have since used it in a few other patients where we certainly see responses. What we also find is that in patients who don't have severe cardiac disease, but severe autonomic dysfunction, the hypertensive side effect of carfilzomib actually makes a big difference to the blood pressure. And patients get their treatment on Tuesday in our clinic. And by Saturday, they're demanding, why can't I have a second dose? Because I felt so well for 3 days after you gave me that drug. We then did this study, which took a long time to do. The study was designed in the early part of the last decade, and therefore we had thalidomide. And we used carfilzomib thalidomide dex in a phase 1 manner. We had 45 milligram per meter squared once weekly as a dose of carfilzomib. We showed that in patients who had relapse disease, even with cardiac involvement, this was tolerable. We had no cardiac complications. We had no deaths. And as you can see, the blue and the blue-green things are CR and VGPR, and we did get a fairly a good number of responses in this particular cohort. Within the UK, now we have access to carfilzomib Lendex as a second-line treatment for myeloma. We use it for amyloidosis under the broader umbrella. And certainly within our hands, we have got a small number of patients who, particularly if they're progressing on frontline DARA-based treatment, go on to get carfilzomib-based treatment second line. We are very strict in the patients we select, so we take patients with what we call as good cardiac function. There isn't a very strong definition for that. Patients with a preserved GFR, good performance status. We monitor them very closely with BNP and troponin. We do an echocardiogram at baseline at every 3 months. We find that the creatinine goes up and down on carfilzomib, but it usually settles back to baseline. And we either use carfilzomib with very low dose len or just carfilzomib dex using a weekly protocol. And it's certainly very deliverable in patients, and I think we need to think more about this drug, which is useful in this setting, particularly in patients who are progressing following a bortezomib-based regimen. We heard a lot about venetoclax, so I won't touch on this. But BCL2 pathway is activated in stress, and we certainly have the light chain, the plasma cells in amyloidosis being super stressed. There are a lot of different agents, not necessarily venetoclax on its own, but also other agents which act on the same pathway, the so-called BH3 mimetic agents. And we really need to have trials with these drugs in amyloidosis. We haven't had trials. We're using them off-label. And I think we need collectively to study these drugs because the responses are very quick. The drugs are really well tolerated, and the off-target side effects are much, much less. And 50% of the patients could be suitable for treatment with these drugs. And certainly a very, very important potential therapeutic options for patients with relapse disease. You've seen this data before, so I'll skip this. Belantamab, you've again seen this data before, but we like belantamab in amyloidosis because apart from the ocular toxicity, which is definitely a challenge when used 3 weekly, it actually gives good responses. You saw this data from the prospective EMN23 study where the overall response rate in DARA-naive patient is 70% and in DARA-exposed patients is just under 50%. But there was a significant proportion of eye toxicity. We updated our results, and somebody showed this slide earlier that in 31 patients, the overall response rates with single-agent belantamab in this cohort, we had CR plus VGPR in nearly 60% of the patients. In this, our dosing strategy has been to give it every 6 weeks, and in some patients, every 2 months a single agent, and in some patients, we've given it with steroids. We really haven't seen many off-target effects. We had one patient who got severe thrombocytopenia. We had a couple of patients who had abnormal liver function tests, but much beyond that, we haven't seen serious problems. So I do think this agent needs more study. What we have now seen is that within this study, we've had a couple of patients treated at our center who had started progressing on belantamab, which was used as fifth-line treatment after lots of initial therapies. And we now have two big phase 3 clinical trials published in myeloma, one with bortezomib, one with pomalidomide. And we thought we'd try adding bortezomib to belantamab to see what happens in these two patients. So this was one of the patients who had belantamab after 3 previous lines of treatment. We didn't really get a very good response to belantamab in this patient, and he started progressing on belantamab. All the way through this patient's NT-proBNP was about 8,500 to 9,000. We added once weekly bortezomib, and as you can see, within the second cycle, the patient went into a CR. But patient really didn't tolerate the addition of bortezomib, so we had to stop treatment, and the patient remained in the CR and has now started progressing again. So we have to figure out what we do. This was a different patient, mainly with soft tissue amyloid and about 20% plasma cells at presentation. So he had VC'd and transplant, had len maintenance, progressed, then had dara-pom-dex for about 4 years and then progressed on dara-pom-dex. Then had single-agent belantamab and really got a very good response, but didn't last very long. And then started progressing on belantamab. But then when Velcade was added in, literally after the first 2 doses, went into a deep CR straight away. So I think even in our population where we had patients progressing on belantamab, we are seeing responses when bortezomib is added. So I think we do need a study of belantamab bortezomib in patients with amyloidosis. It's really easy to use. Belantamab can be given every couple of months, and then bortezomib could be given less frequently if needed. We saw this in different guises earlier on about bispecifics and CAR T cells as active immunotherapy to target. We have got a few clinical trials that are opening up at various places around the world, particularly with bispecific antibodies targeting BCMA. We have got a Sanofi trial with NK cell CARs, which will hopefully open once the myeloma cohort is recruited. And of course, we saw some data on the academic CAR T cells coming from our colleagues in Israel, which is now going into phase 1-2 trials in the US. I'm not going to go into details, but what Arno showed and others showed before is that the responses are very deep. But what's very striking with the bispecifics is that the light chains become undetectable. They are below 1 milligram per liter, and we don't see this with absolutely anything else we use treatment for amyloidosis. So I think there is a big role for these drugs because we see very, very deep responses. We don't see CRS as a huge problem in these patient cohort, but of course we have the long-term problems of infections that we do need to address. We have other targets apart from BCMA, and this was one of our patients who had, again, progressed after multiple lines, soft tissue amyloid, cardiac amyloid, myeloma with 30% plasma cells, 1Q gain, treated with CTD about 20 years ago, then had a transplant, then had Lendex, then went on to Darapomdex, remained in a remission, then progressed, added cyclo, responded again, progressed, had belantamab, as we normally do, didn't really respond well, got very significant eye toxicity, so we stopped. Then very cautiously, we gave carfilzomib and Dara for this patient, got a response which lasted for about a year, but then progressed with rapidly rising light chains. At this point, we wanted to give him a bispecific because we had access. We wanted to use teclistamab, but the patient had heard about some data which had been presented that patients with teclistamab don't respond so well to CAR T-cell treatment, and he has decided he wants to have a CAR T-cell treatment, so refused teclistamab. We had a second consultation with Professor Sundar Jagannath at Mount Sinai, who suggested we should go ahead with talquetamab. So he had talquetamab in March and immediately normalized his light chains by the time he received the full dose. He has some macroglossia. He started getting the typical side effects of talquetamab with dysgeusia, has lost a little bit of weight, but the weight is now stabilized and he's ongoing every 2 weekly on this drug. We have seen this data on CAR T cells, and we look forward to other studies. There are other CAR T cells with different targets, and we are hoping that we may have an academic CAR T cell study targeting CD19 and BCMA in due course. So this is our patient population. I showed you this graph earlier. Maintenance, no maintenance, progressing on DARA, off DARA. What is the real-world experience? You saw this slide from a couple of people before, but what's quite striking is that the number of treatment regimens that have used in this study from the Mayo Clinic is very wide. All sorts of regimens, IMiD combination, DARA alkylator combinations, BCL2 inhibitors, and stem cell transplant. Of the cohort, I've lost my slide, if I can go back, yeah. So 6 out of 9 patients had a CR with stem cell transplant in that particular cohort, whereas the other responses were mainly with BCL2 inhibitors. So we really do need to study this. So I'll end on this last slide. What can be our treatment algorithm for patients who have an inadequate response to first line, or who have a CR-VGPR and progress, or those who have an organ response will of course continue to observe, but once they start progressing and we have to decide what this progression means, we then have options of IMiD-based regimens, which most of us have access to some form of an IMiD-based regimen. So these are something that's quite easy to use. And we certainly would go for IRD if we had an option there, or a POM-based regimen. We have got other proteasome-based inhibitor regimens, so we certainly will use in patients who have got no significant cardiac involvement a carfilzomib-based regimen. For T1114, venetoclax is a great option, but again, not everybody has access to that. And then we have the option of BCMA-targeted therapies. Where do we use them, 5th line or 2nd line? And hopefully we'll have trials coming through which will tell us what to do. Of course, this part is easy. If we have not had DARA before, treat with a DARA-based regimen, which could be DARA-DEX, DARA-VD, or a DARA-IMiD combination. We have to consider transplant. It's a really important modality. I think we get deep responses. We have had a bunch of patients now treated with DVD who have had transplants, who are in deep response, and where we don't have access to novel therapies or licensed novel therapies, stem cell transplantation would still have a role, although I know that's quite a disputed statement to make. But I think we have got a number of different treatment choices. We need to harmonize our approach because at the moment everyone's doing something quite different, and there is no standardization on what the second-line treatment is for patients who are progressing after initial frontline treatment with amyloidosis. I think we have got a number of clinical trials that are going on. Most are phase 1, phase 2 studies. I think Yuta is going to talk about trials next, so I won't go into details. But we do have trials with belantamab. There's one trial which is open with venetoclax now. We have got trials with DARA in combination. We've got CAR T-cell trials, and we've got at least 2 immunotherapy trials, including with bispecific and trispecific antibodies in patients with AL amyloidosis. This is basically a drawdown from clinicaltrials.gov that I did yesterday. So with that, I'll end and thank all my colleagues at the Amyloid Center. A lot of the treatment stuff I presented is at University College Hospital, and thank all my colleagues there, and to all our collaborators whose data I presented here today. Thank you.